Okay.
Okay, so we are starting the session. Good evening to all. I welcome you all to the session of lecture series, the second session of lecture series, which is held in connection with MEDMEET, International UG Conference, organized by College Union 2020, Government Medical College, Kozhikode. Myself, Raisa Rani James, first year MBBS student, Government Medical College, Kozhikode. Well, as you know, this is a platform which is a break to all the competitions. Over here, we discuss certain medical affairs in association with certain faculties related to those topics. And today, we are here with the topic, the art of radiology. And we have with us the eminent radiologist, Dr. P.V. Ramachandran, sir, currently working in Ayr University, Scotland. He was a former principal and he was a director of medical education. For over 30 decades, he's been in the field of radiology and has worked in almost all medical colleges in Kerala. We are very proud and happy to have you here, sir. I welcome you to this session. Now, before going to the session, let me give the general instructions. After the session is over, if the viewers have any kind of doubts, you can post them in the comment box and we'll be dealing with it after the session. Okay, sir, over to you.
Okay. I can start now, I believe.
Yes, sir. Yes, I can start presenting.
Okay. Thank you for your nice introduction, Raisa. We will start our class today. As you know, the topic has been given to me by the organizers, which was termed Art of Radiology. So I was a bit confused, especially when taking a class for undergraduates. Where should I start by mentioning Art of Radiology? So as usual, as like all people do, I also went to Google. And what I found is strange things. When you Google for Art of Radiology, you find a cat saying something about the CAT scan. And on the left side, you see a Belgian artist doing stained glass paintings. And third is a whole body image, as you get in a PET CT or in a whole body MRI, etc. So naturally, I just left that phrase. This is not what we are supposed to do, I know. So the contents of today's presentation are, basically, I am revisiting a fundamental tool called chest X-ray. Even though we have a lot of modalities now, in addition to we have ultrasound, we have CT, we have MR, we have other digital imaging, we have nuclear medicine. But one thing which has not lost its significance even after 100 years or 125 years exactly is chest radiograph, which is a very cost-effective investigation, which tells you a lot. So today, during the next 45 to 50 minutes, we'll be covering principles of chest radiography, basic reading methods, and about a dozen common chest radiology signs from which you can reach major diagnosis from chest radiography itself, so that you can subsequently further evaluate them for better characterization. Then, being about chest X-ray, I should tell you something about lung cancers also. And finally, we will go to some of the pitfalls and missed opportunities also. So it was customary for me to start all X-ray classes and radiology presentations with these 4 slides. You know what is this room? This was the room, dilapidated laboratory of William Conrad Röntgen, where sitting in you can see his laboratory room in the top floor. This is the building of Würzburg Physical and Medical Institute in Lennep in Germany in 1895 fall. You can see the trees are without leaves. Late evening, he was working and he happened to discover X-rays. And it really changed the medicine, the whole approach for investigations. And at the end of 6 weeks of continuous re-experimentations and documentations on physical and chemical properties, he finally called his wife, Anna Bertha Ludwig, to the laboratory and took what is called the historical radiograph, which you see on the left side. And see the improvement which he made within the next 6 weeks. See, this was on 8th November 95. It was on 4th January 1896. He gave the first presentation to the Würzburg Physical and Medical Society. And then at the end of the talk, he called the president of the society. He was an anatomist called von Kolliker and took a radiograph of his hands. That is Next one. So this is the history of radiology, and this year exactly we are 125 years from that discovery. So I said I'm going to talk to you about chest X-ray. This is a this is again another historical chest radiograph, which is several years old, more than a half century old. I just kept it here, even though it is not a very good radiograph, just to show the perfection of the radiograph. It has been very well centered. And you can see that the scapulae have been well moved out of the lung fields because the patient has been positioned properly. What was special and historical about this particular chest radiograph is this one, discovered from some store after 50 years or so, it went for auction last year with an unbelievable $50,000 because this particular radiograph belonged to Marilyn Monroe. You know who was Marilyn Monroe. So, and let us go see how radiographs are being done. In the olden days, even to get a radiograph of a child, you can see there are 2-3 people there. They are not taking proper precautions. They are not wearing lead aprons, etc. And it will take a long time because the time for radiography, exposure time used to be long. But nowadays we have quite modern machines, and we don't use films and cassettes anymore. They are all digital equipments, and it's much faster also. Always in radiography, there is a debate on the views. You might have heard about the PA and the AP views. So most chest X-ray films are ideally taken as a postero-anterior, which means, as you see in the picture, the X-rays shoot through from back of the patient to the X-ray plate in front of the patient. But sometimes if the patient is too sick to stand up for this, you'll have to agree for an AP film, antero-posterior film or exposure, in which case the patient will be lying down on a table and the beam will be coming from above. So there is if a radiograph has been labeled as AP, it is taken as an antero-posterior. But if nothing is written on the image, it is safe to assume that it is a postero-anterior. Why do you prefer postero-anterior exposure? Because it's always better for obvious reasons. Spend a little bit time for this image. In the upper one is an antero-posterior thing, where you can see the tube is nearer to the patient, and since patient is lying supine, the heart is more towards anteriorly. So there is a little bit of magnification. Whereas coming to the lower one, where it is taken as a postero-anterior, where the X-rays are shot from behind, the heart is closer to the documenting surface, whether it is film or a digital plate. And moreover, this is called a teleradiograph, where the patient is standing 6 feet away, and therefore less chances of magnification. So the heart size is nearer to the real. Now you know why we prefer always a postero-anterior tele-chest radiograph taken at 6 feet distance, patient in standing position, patient facing the documenting surface. But as I said earlier, because of reasons like a patient cannot stand for a few minutes, patient is very sick, etc., you will have to agree for an AP projection lying down position, which is a slightly compromised one. What do you see in a chest radiograph? There are several things which you identify in chest radiograph. All the numbered things there are identifiable structures. You can read them. Actually, it has been, the legend is there on right side. So you can identify heart, you can see the costophrenic angle, cardiophrenic angle, diaphragm, clavicle, ribs, even spine, the bony cage, and the lung parenchyma in between. But remember that there are quite a few things which you will not be able to see in a chest radiograph, but which are very important. The typical one is an esophagus. See, because they are in a straight line. So unless the esophagus is diseased, for example, there is a mass arising from the esophagus, an exophytic mass, or an achalasia cardia, a dilatation of the esophagus, you won't see esophagus. Similarly, sternum, unless you do an oblique view or a lateral view, you will not identify even an external fracture from a chest X-ray PA view. And pleura, unless the pleura is diseased, for example, suppose there is air or fluid between the pleural layers with pneumothorax or pleural effusion, then only you see that structure. Otherwise, you don't see the structure called pleura. Similarly, the number 6 is marked as the aortic knuckle. The aorta comes back to the midline, and unless the aorta is diseased, as in an aneurysm or a dissection, you won't see that also. So while seeing the chest radiograph, remember 2 things. One, you're not seeing everything in the thorax. There are many structures which are invisible, which are equally important. Second thing is, you actually have only 40% of the lungs available for viewing, because the rest of the lungs are masked by the bones, the clavicles, the numerous ribs, the spine, the diaphragm, etc. So you have to be very careful while screening a radiograph. And how do you get these different appearances in chest radiograph? That is because the different tissues in our body absorb X-rays to different extents. See, through the air-containing lungs, X-rays will pass through. None of them are absorbed. So they reach the other documenting surface, and you see those areas are black. Whereas through the bones or through the spine, that much of X-rays will not pass through. Several of the X-rays are, the radiation is absorbed. So that will be seen as white. And in between, there are several tissues like fat, muscle, fluid, etc. So all these things will be having a differential attenuation. So in other words, the contrast or the information which is available in a chest radiograph is because of the differential absorption of X-rays by different tissues in health as well as in normalcy. Now comes to a fundamental question: how do you read a chest film? Is there any accepted method for that? From your medical school days, that is exactly now, you must be bombarded with several ways to read a chest film. Each will be claiming that their way is the best way. But I would suggest two simple ways. Both are equally good. But remember that the first rule of the thumb when you look at the radiograph is make sure that the correct patient's name is on the X-ray. You are looking at the right film or right image. So the first method, I will just call it ABCDEFGH. You know why? Air stands for airway. Look at the trachea and main stem bronchi. Are they patent? Is the trachea midline? Which tells you about the positioning also. It should be midline normally. B, bones. Look at the clavicles, ribs. Sternum, of course, you can't see. But are you seeing any fractures of the upper end of humerus or something? C, cardiac silhouette. You're seeing the heart shadow against the black lungs. Do you think there is cardiomegaly? D, diaphragm. You can see both dooms of diaphragm and the angles, that is the costophrenic angle as well as the cardiophrenic angle. Both should be very sharp. Are you seeing as sharp? Just for convenience, I have put E is for effusion as well as empty space. Empty space means air. Do you think there is air or fluid in the pleural cavity? And now you look at the lung fields. Look for findings like infiltrates, increased lung markings or opacities, which can represent masses. Air brogograms within an opacity, which will tell you that it's a consolidated lung. I'll look at the silhouette sign, whether some part of heart is not seen very clearly. Then finally look at the gastric bubble. Is it present? It should be seen if it is an erect patient, and it should be seen on left side. Look at the hilar regions also. Hilar region means you can see the left hilum will be slightly higher compared to the right. Or otherwise, you just you can have a random method also. Just check about see whether you are happy about the penetration of the radiograph. Has it been well penetrated? Second, verify the side and by looking at the gastric bubble. Then check for the rotation by looking at the clavicles. The medial ends of the clavicles should be equidistant from the spine normally. Then see whether the radiograph has been taken in full inspiration. Normally, you should be able to see 10 posterior ribs or 6 anterior ribs. If it is less than that, that means it is an under-inspired radiograph. When it is an under-inspired radiograph, less lungs are visible to you, and the visualized lungs will look a little opaque. So they are not basically good for viewing. Sometimes you might even need to repeat the chest radiograph, correcting if there is any centering abnormality, and as well as correcting the exposure factors to give the proper radiation dose and correct penetration. And now see whether it is an AP or PA film, which I already discussed with you. Check the soft tissues for a foreign body over here. Check the visible bones and joints. Look at the diaphragm for free air or abnormal elevation. Check hilar and mediastinal areas. Check the heart for size, shape, etc. And now look at the costophrenic angles and cardiophrenic angles. And finally, the lungs. Look for opacities, increased interstitial markings. And it has been checked whether is there the radiologists, we trained people, do we really look at the film differently? Studies were performed with the special helmets which will bounce a ray of light of the radiologist's cornea when he is looking at chest X-ray. But what has been found is there is no standard pattern. Everyone looks in his own methods. Even though you see these three patterns are from three different radiologists. But even when we say that different people look at differently, there is always a difference between the eyes of the trained eyes as well as untrained eyes. So even if you are not a radiologist, if you are looking at a radiograph, you should have a trained eye for that. See, look at these two pictures below. There's no point in staring at a radiograph. It won't work. There's no point in looking at it for 5 minutes, but you are not looking everywhere. See the right side one. The views are just centered around the midline structures, heart, mediastinum, etc. Whereas a trained eye will be always looking in a different way. So it will cover almost all the areas. That is what you see on the left side of the image. Now, there are several things when you look at the chest area. This is slightly under-inspired, and I don't say this is under-inspired, but it is under-penetrated. Do you find any abnormality between the two sides? It's a little difficult because it is a slightly underexposed radiograph, but I will show you one more. This one, do you find anything different? Always exploit the bilateral symmetry when possible. If you just look at the thorax as a symmetrical structure and you exploit the bilateral symmetry or look for an asymmetry, by this time, you would have probably found out that the left breast is absent. That is why the left side looks darker. So there has been a mastectomy on that side. That gives you additional responsibility. Now you have to look at for any lung masses as well as any findings in the bones, etc. But see that the breast shadow is visible on right side, but not visible on left side. But it may not be always due to the same reason. See this one. What is happening in this chest radiograph? There is a little bit of obscuration in the left lower zone, but that is probably due to slight rotation, which has happened while radiographing this patient. But even here also, it's a male patient, you are not seeing perfect symmetry. You find that the right side is darker. But in this case, it's due to a totally different reason. Look at the CT scan of this patient. What do you find? You are not seeing the pectoralis major muscle at all on right side. So this is a congenital condition, very rare condition called Poland syndrome, where the pectoralis muscle is congenitally absent. So when that is absent, that side will look darker. In other words, other than the mastectomy and this very, very rare Poland syndrome, there are quite a list of conditions where one side of lung can look dark and one side can look brighter. So you have to look for that carefully. This is another set of X-rays. Did you find any abnormality? In fact, sometimes it is very difficult to declare a radiograph as normal. Sometimes it will be very difficult to say that this particular radiograph is normal. Having looked at it for a few seconds by now, did you find an abnormality in that? Some of you might have noticed the abnormality, I'm sure. I will give you a single image from another patient which has the same condition. This one probably you would have noticed. The clavicles are just absent in this case. See, even if the clinical history has not been given to you, you should be able to spot it. That is another training which you develop by looking at radiographs, looking at hundreds and subsequently thousands of radiographs. That is, there are two things. The second thing is your knowledge. For example, the eye will see only what the mind knows. That is one radiological dictum. But before the question of mind knowing and your knowing pathology and applying into your findings, the first thing is to observe. So your observing skills should improve. So by this time or by the initial days or initial years, you start looking at everything so that you just start looking. For example, you looked at heart, you looked at lungs, then you don't look at the bony cage just vaguely. You find some problem with the scapula, then the ribs are there, the clavicles are absent. So this is a cleidocranial dysplasia, cleidocraniodysostoses. So I gave you this example to say that looking at a normal X-ray is sometimes really, really difficult. And these are also actually normal radiographs of 3 children. Obviously, you can see that they are child X-rays. What are you seeing as a triangular sort of shadowing to the right side of the mediastinum? It's seen clearly in the right upper one and the lower one. This is due to thymus, which is a normal finding many times. And usually it is seen on right side, where you call it a sail sign. But sometimes you see it on left side also, as you see it in the upper part. Sometimes you will see it as a big mass also called thymolipoma. So in other words, the most common reading for radiographic study is a normal or a normal variant. But see, this is another thymus, where you can see it is significantly projecting towards the right side. In fact, someone even thought it could be a mass and did a CT scan, which I should say is criminal, because in a child, you should have first thought that it is likely to be thymus. You probably would not be doing a CT to confirm that it is a thymus unless there is a thymic tumor or something. And similarly, positioning. I told you about AP and PA radiographs. Similar to AP and PA, the patient should stand erect and stand properly without adopting a kyphotic or a scoliotic posture, without being lordotic. If patient start putting his head backwards or front, etc., you get all these sort of grotesque abnormalities as you see in the 3 radiographs above. Actually, it is the same case which you see as the normal chest radiograph in the right one below. So therefore, never hesitate to repeat a mal-positioned chest radiograph. So the first pearl which I told you was exploit the bilateral symmetry of the thorax. Second is check out these areas twice. These are dangerous areas where lesions left to hide behind the hyla, behind the heart, at the lung apex on either side, and also at the costophrenic and cardiophrenic angles. So look at these places carefully. You can miss lesions in these places. Now I'm going to nearly a dozen radiographic signs which have stood the test of time. They are here for almost, see, if X-rays were discovered in 1895, from 1896 itself, we have started taking chest X-ray. So you can say that chest X-ray is 125 years old now. What do you see? You find that there is a loss of the contour of right heart border. And in the lateral view, you see that is actually occupying the anterior portion. But which is that portion? It has to be middle lobe. Why? Middle lobe is abutting the heart border. So if you see that the cardiac Silhouette is absent, or it's called Silhouette sign, or rather loss of Silhouette sign, correctly, to be correct, it means most likely the middle lobe is consolidated. The same thing can happen on left side also, where the culprit will be the lingula. A lingular consolidation will look almost like a middle lobe consolidation in the lateral view, but in the PA view, it shows that the left heart border is now absent, or the left cardiac Silhouette is. Look at this picture. This is what you see when you take a photograph of somebody standing on a beach, in an evening. You only see the outline of the persons or outline of somebody standing there. So that is what is called Silhouette. So that's how the word came into English literature. And it's basically a French word. It belongs to the name of a French finance minister of the early 20th century. That is, his name was Etienne de Silhouette. It was his hobby to cut shapes and the morphology of the people who are sitting in front of him. When somebody is coming to see him, he will take a cardboard and a scissor and make a small cutout of his figurative outline. So that is from him, the word came to all the languages, and now it is a radiological sign called Silhouette sign. This is another sign, which is a very important sign, which has again stood the test of time. You find a little bit of vagueness on left side. It's not what you call as sharp or as transradiant as right side. And in spite of it being, there is a diffuse haziness, you see that the aortic knuckle is clearly seen. I have marked out the lucency around the aortic knuckle. So there is an opacity, there is a wheeling effect in the left hemithorax, but at the same time, the aortic knuckle stands out clearly. What is happening is, this is a left upper lobe collapse. When the left upper lobe completely collapses, you will not identify the lobe as such in chest radiograph, because the left lower lobe will compensate it to a large extent and occupy almost the entire hemithorax. But because it is hyperinflating and compensating, it will go and outline the aortic knuckle. That is why that sickle-shaped lucency is there. And this is a German word. Luft means air in German, Lufthansa, etc. Sickle means same thing, S-I-C-K-L, sickle. There is a sickle-shaped. So it is a sickle-shaped air lucency which is responsible for this finding, which gave its name called Luftsichel sign. Do you want proof for it? Yes. If you do a CT scan, you will see what is happening. You can see that the left upper lobe is not a dark structure, it is a solid structure, as you can see in the first image on right side. And when you do CT, you have a facility, unlike in chest radiograph, you can vary the window, but you can manipulate the attenuation characteristics. For example, what you see as black on right side is due to air. What you see as white on left side is to bring out that details of the lungs, you reduce its parameters, then you identify the lung and lung vessels clearly, but then you can't see the mediastinum clearly. But in the right picture, you see the mediastinum and aorta and collapsed the lung. The lower images are the corresponding coronal images of the same Luftsichel sign. Now we come to a third important sign called S sign. Ideally, this should be called a reverse S. If you look at it, see the bigger arrow shows the upper part of the S, and the lower arrow shows a mass which is preventing the collapse of the right upper lobe. So when there is a primary mass lesion or a metastatic lesion in the right upper mediastinum, which is preventing collapse and approximation of the upper lobe towards the mediastinum, then it produces a sinuous shape. This is called, basically, this is not an S, this is a reverse S. So this golden S sign, if you find in a chest radiograph, it is an indirect evidence. In this case, of course, even directly you can see the right side and the hilar mass. But even without that, even if you only see the reverse S sign, that is a dangerous sign implicating a primary or metastatic malignancy in that region. So this is another case of golden S sign. You can see the reverse S shape, which is manifest in the right upper zone, which is due to the density. On left side, it is a different case where the mass is a little more bigger, but still the shape is same reverse S. We got a fourth sign called deep sulcus sign. So normally it is easy to identify pneumothorax if it is large, because it will produce displacement of the mediastinum, and also that lung will be unduly blacker and it will be devoid of any vascular markings. But if it's a small pneumothorax, it's a bit difficult, even in a posterior view, erect view, because it will be seen only at the apex. But as I said earlier, sometimes the X-rays are taken because the patient is very sick. X-rays are taken in the supine position. Then what happens? Then the air floats, air goes to the uppermost portion. So you will find that look at the lower picture on right side. You will see that the arrow points to a deep sulcus. That is the upper part, and the air has floated, and air is outlining the edge of the right dome of diaphragm, outlining the right costophrenic angle clearly. Even on left picture also, you can see a similar darkening adjacent to the left cardiac border. So these deep sulcus sign also indicate pneumothorax, especially when they are in a supine position. The patient is radiographed in a supine position. Something more is there in the right side picture. It's not clear. You see a lot of linear air lucencies outside the thorax also. How do you explain that? That is also something which occurs along with pneumothorax. The air has escaped to soft tissues, subcutaneous tissues, which is called surgical emphysema, in which case it sometimes infiltrates the muscle. You even see the fibers of pectoralis major, etc. This is a difficult sign. This one, Okay, something was masking. This is called fallen lung sign. Fallen lung sign describes the appearance of the collapsed lung away from the mediastinum when you are facing tracheobronchial injury also simultaneously. I told you earlier, when there is a pneumothorax, what happens? The air accumulates and it compresses the mediastinum. It compresses the collapsed the lung. So the lung will be approximated towards the mediastinum. But sometimes you will see that the lung is falling outwards. See the next picture also. If you see that, that means there is an injury. There is a severe injury at the tracheobronchial tree also. So this is called fallen lung sign. Now, we discussed about Golden's S diagnostic sign, that the reverse is golden when a primary or a metastatic mass lesion is there in the upper mediastinum. But other than that, also fibrotic diseases can occur in the lungs. See, look at the central picture. Normally, you should have seen right hilum a bit lower down compared to the left. But here both are at the same level, or rather the right is slightly higher. And you look at the upper zone of both X-rays on the sides, there are a bit of fibrotic lesions. When these things occur, they pull certain structures and make them visible or prominent. The structures which are normally invisible in a chest radiograph, like an inferior pulmonary ligament or an accessory lung fissure. Actually, there is an inferior accessory fissure which is present in almost 30 to 40% of patients. But normally you won't see that. But when there is a disease in upper zones and fibrosis, you see that is in chest, it produces a tenting of the diaphragm. So which is called a Juxta phrenic peak sign. You see that, look at the left picture. You can see a small tenting or peaking of the left limb of diaphragm. Another one called the continuous diaphragm sign. Even though diaphragm is a single muscle, normally you identify it as two different structures. You identify it as a right dome as well as left dome. But if you are seeing it as a straight line, if you see an air lucency outlining the diaphragm, which only means either there is air above, which is pneumomediastinum, or there is air below, which is due to pneumoperitoneum. Sometimes even air in the pericardial cavity, pneumopericardium, also can cause this outlining. This is called a continuous diaphragm sign. The commonest times when you see that it is in pneumomediastinum. I'm coming towards the end of description of signs. This is, can you see the hilum? Hilum is that structure. Basically, it is, even though we say hilum, even though there is pulmonary bronchus and these divisions also, essentially the hilum is constituted by the pulmonary artery. That is the main structure. So you'll see the pulmonary artery and branches. But suppose you see an opacity with its outer border far lateral to the pulmonary artery and branches, and you can still see the pulmonary artery through that, which is called a hilum overlay sign, which means that the mass is not in the same plane as the hilum. It is either anterior to it or posterior to it. Commonest situation where you get a hilum overlay sign is through the thymic mass lesion, whereas thymus is basically in the anterior mediastinum. And I'm coming to probably one of the last signs, which is called a cervicothoracic sign. In all these three different cases, you are seeing that the upper limit of the mass is above the clavicle, which can happen only if the mass is in the posterior mediastinum. If you classify, there are more newer classifications for mediastinum. The conventional classification is superior mediastinum, which is above an imaginary line between the T4 vertebral body and sternum, and all structures below are divided into anterior, middle, and posterior mediastinum. In fact, the commonest masses in the anterior mediastinum all starts with the T: thymus, thyroid, teratoma, and sometimes lymphomatous masses, which are called terrible lymphoma, to remember 4 T's. But here, clearly the mass is posterior. You know how? Because the anterior mediastinum does not go above the clavicles. By the time the clavicles are there, the chest radiograph, the anterior mediastinum stops there. So in all these three cases, it indirectly tells you that the mass is behind and posterior mediastinum. It can even be a lung mass, which is involved in the apex of the left lung. But primarily, as you see in the central picture, these are posterior mediastinal masses like ganglioneuroma, etc. There are several small books, small means 100 to 200 pages books available. You will find at least a dozen of them. In fact, some of them are written quite smartly by very young people, very young registrars who have recently appeared for examinations, etc. So it's a good idea to have one of those books with you, as a survival guide to look at chest X-rays, just for fundamentals. My choice in these three will be the one on right side. It is not simply X-rays. They give you a little bit of information, or rather, it almost gives equal importance to CT scans also. And CT of the thorax is a natural accompaniment of chest radiographs nowadays. Only thing is, you start with chest radiographs because it is commonly available, because it can be very quickly done, and because it is a very cost-effective investigation. Now I am going to some cases, which are quite important cases, quite rare diagnosis, etc. But the chest X-ray will tell you that. It's only because you suspect it from chest radiograph, you order a CT scan of the thorax and confirm it. See what is happening in this chest radiograph. You can see the left lung, something wrong with the right lung. It is not pushing the mediastinal into the other side. Instead, there is some sort of thickening developing all around the lung. Not only the mediastinal pleural aspect, the costal pleural, and even the diaphragmatic pleural aspect also. You can see an opacity even crisscrossing that. I'm straight away going to the axial and the coronal views of CT scan of this patient. Both you can see in one frame. What you see on left side below is a coronal image. You can see that there is an irregular lobulated soft tissue thickening lining the mediastinal pleural surface, going up to the apex and coming down through the costal pleural aspect and involving the diaphragmatic pleural aspect too below. But in between it is spreading through what? It can only be fissures because the fissures contain pleural layers. What is this? This is a rare diagnosis, but we come across it frequently. You know why? We come across it frequently because of its association with a substance which was widely used in previous decades. I'm talking about a pleural mesothelioma, which is induced by asbestosis. So even if the asbestos exposure is not dose-related exposure, you get two types of asbestos-related lung diseases. One is asbestos-related interstitial lung disease. Second is asbestos-related pleural mesothelioma, which develops after 30 to 40 years. The exposure may be just one time and very slight, but that is enough to induce this change after several years. So in a plain radiograph, you will see that the tissue thickening is surrounding the lung and encasing the lung. It can even go further. It can pass below. It can penetrate the diaphragm. It can penetrate the chest wall and produce lymph nodes. And coming to CT, you will demonstrate all these things much better. The pattern of spread will be better described. You have only very few differential diagnoses with this appearance. The one main differential diagnosis being metastasis from adenocarcinoma, which can be continuous lobulated masses like that. But if you are able to elicit a history of asbestos exposure, pleural mesothelioma is the diagnosis in this case. Sometimes chest radiographs can be very confusing like this. See, normally the left diaphragm is, you find that left diaphragm is lower and right diaphragm is at a slightly higher level where the liver is there beneath it. But all this can change. Here, actually, this patient had a very long-standing elevated left dome of diaphragm, which can occur just due to a congenital weakness of the diaphragm, which is called eventration of the diaphragm. On right side, similarly, you can have one or two diaphragmatic humps, which again represent weak areas of diaphragms. But here something more is happening. Not only that, the left dome is markedly elevated, beneath which there is a large fluid level. That means, along with the elevation of the diaphragm, the structure underneath also has gone up. At least now it is intrathoracic. And you might need further investigations, as has been done in this case, in which the displaced stomach has actually undergone a rotation. If you look carefully on left side, you can see the gastroesophageal junction in the upper left radiograph. Okay, this one. But then, if the barium, after the barium has been administered further, you can see that the stomach is upside turned down and it is coming back. So finally, the stomach, the pylorus is back in stomach. So what is happening? This is called gastric volvulus. Along the two fixed points of gastroesophageal junction, that is here, as well as the gastroesophageal junction and the pyloroduodenal junction, along these two fixed points, the stomach can just flip upwards. That is called organoaxial rotation. But if it is undergoing a rotation in a different axis, perpendicular to that, Then this is called a mesenteroaxial. So both these have got different situations. For example, the organoaxial volvulus is very common, more common in adults. It's common with the trauma or hernias. For example, suppose there is a diaphragmatic hernia. I will come to that a bit later. The stomach which is displaced can undergo volvulus, which can sometimes undergo it also. It can be cured by itself, but most of the time it could be of acute nature, because the degree of obstruction can be 180 degrees when it is going to obstruct. Whereas the mesenteroaxial is not that common, but it is commoner in children. It is more of a chronic event, and the rotation is mostly incomplete, and it is usually not associated with the diaphragmatic defects. See, this is the first, what you see on right side is a classical organoaxial volvulus. You can see that the stomach went up. Actually, the stomach, esophagus came down and the stomach started somewhere here, and the stomach went up. And the greater curvature, which should be normally below like this, has flipped upwards. So this greater curvature is up and lesser curvature is down. And this to the same gastroesophageal hiatus, esophageal hiatus, the pylorus comes down and the stomach continues. So this is the organoaxial volvulus. Whereas in mesenteroaxial volvulus, you can see that it has twisted the other way around. It has not gone into the stomach, but it has twisted. Then what is this? Do you think this is an event ration? No, it's quite localized, but it's not simply a diaphragmatic hump. If it was simply a diaphragmatic hump, you would have seen liver with the same density here. It's quite massive, and you see a lot of scattered lucencies here, which gives you a suspicion of colon. It can only be colon because this is a characteristic condition called Morgagini's hernia, which is an anterior defect of the diaphragm. See, you can see the anterior defect in the coronal view. Through the defect, the omentum, the fat, everything goes up, along with a part of the transverse colon and mesocolon also goes up. So it is the omental tissues which was giving the whiteness there in the chest radiograph, and the blackness there were all due to lucencies from the air. So this is a Morgagini herniation. You can see lateral way, you can see that it is it's going up through the anterior part. See, this is the defect. Through the defect, instead of stomach is normal position. The colon, part of the transverse colon and omental tissues are going up. The same thing can happen on the left side, which is usually through herniation through the posterior defect, which is called Bochdalek foramen, Pochdalek. Remember, all these were described much before the discovery of X-rays by anatomists and also from postmortem studies. Look at this carefully. So the defect is posterior, and look at the side view, lateral view. This is kidney. Actually, the colon has gone up, and in the CT scan axial also you can see the stomach as well as the colon. So it is not only the stomach, colon has gone up. So stomach, colon, and even the left kidney can go up through the foramen of Bochdalek, which is posterior. Now we are talking about mastectomy and Poland syndrome before. I just wanted to mention about a few more conditions which are important as regards the unilateral radiolucency. These two are different conditions. What you find on right side is the large unilateral radiolucency in an infant. It must be less than 6 months old. You can see that it is displacing the diaphragm down and displacing the mediastinal towards our side. This is a congenital condition called congenital lobar emphysema. It was called CLE, congenital lobar emphysema before. Now the new terminology is just congenital lobar overinflation. The presence within the 6 months, and if there are no sufficient alveoli, this might, unless this is very mild, it might need resection and surgery, etc., because it will compromise the other lung also. It might be due to some congenital obstructive elements or some dysplasia or something. Whatever it is usually common on left side. Nearly 40 to 45 patient cases affect on the left upper lobe. Next commonest case is the middle lobe on right side and the right upper lobe. And in 5% cases, you can have it in multiple lobes also. So both middle lobe and upper lobe put together, it is more common on right side. But if you ask a single lobe, it is usually common on left side. But what about the left picture? Definitely there is a difference between these two. With or without a history, when you see such a chest radiograph, you should suspect foreign body. Suppose the foreign body is obstructing, like with a check valve effect on the bronchus. what will happen is air will be trapped on that side. It can be made more convincing by getting an inspiratory-expiratory pair of radiographs. What happens is in expiration, the air will be going out from the normal side, but it will be prevented from going out because of the foreign body. So even without a history, if you find a differential blackening in a child, you should suspect foreign body always. But this is simpler pneumothorax. You can see a massive pneumothorax on right side, which is producing a mediastinal displacement. If it is not that massive, you will identify the collapsed lung margins. But it's very massive in attention pneumothorax, you may not even see the collapsed lung margin. And what about other lucencies? Even though rare, since certain parts of the upper abdomen is available for you as free in a chest radiograph, you should look at them carefully. You know that you can normally expect lucencies on left side beneath the left dome of diaphragm, which is due to the stomach bubble, or sometimes even the colonic bubble. But right side, normally it shouldn't happen. Normally there is liver. Okay, occasionally things like this can happen in a chest radiograph. You see, this is colon. This is a huge loop of colon. This is again massive colon. So colon can sometimes get interposed between the right dome of diaphragm and liver. That is an anatomical variation. But this case was different. This was some sort of a patchy, a little bit of a strange air. And the patient was septic, and other investigations were being planned also. The bloods were coming out. They were looking for infection. What happened is this was a liver abscess with air. So even this much of scattered air within a liver abscess, as is revealed in an axial and coronal CT images, can sometimes manifest in chest radiographs. This is not a good radiograph, but I kept it to show you something. There are multiple findings in this radiograph. Forget about them. There is supposed to be a mass lesion here, and some patchy infiltrates are happening here, and something here. But I want you to concentrate on this area. If you look at here, there is a mass, but the mass has got a small air crescent outside it. Within the mass, it appears that there is a small lucency between the opacity and the cavity. These things will be very clearly demonstrated in a CT examination, but not always in a chest radiograph. But you should look for it, and only you will find it. What is its significance? It is a fungal body. It is a growth of fungal mycelium and hyphae within a dead cavity. If it is developing in a dead tuberculous cavity, you might think it is very innocuous. No, it will be having blood supply, of course, and one day or other that is going to rupture. The blood vessels are going to rupture, and they are going to be usually supplied by the bronchial arteries. So it will be blood with systemic pressure which is going to them, and the patient can present with a massive hemoptysis. So try to look for a lucency which is bordering a clot inside a cavity. Now aorta. The lower is a little advanced investigation called transesophageal echocardiography. If you do that, you identify aorta and you identify a dissection, a membrane in between. But in plain X-ray also, sometimes you can suspect it. Normally, the X-ray, as I told you, aorta is a very confusing structure. You just get the aortic knuckle, it should go down. But depending upon the age, tortuosity of aorta can set in, and you can get an aortic unfolding. But if you see carefully, the calcium is not at the edge of the aortic margin. Normally, the calcific plaques should be away. It should be at the periphery, involving the adventitia, But instead, if there is the intimal calcification, and between the adventitia, if there is a distance of 1 centimeter, which is called the calcium sign, which says that something else is happening in the aorta. So this is what is going to happen. So this is a CT scan. You can see this is the Mercedes sign. You can see the membrane, that is the intima has come inside and ruptured. So there is a double lumen for the aorta. See, so just with the mediastinal widening, sometimes you suspect this. And you can't say no, or you can't refuse when somebody says there's a history of chest pain and the mediastinum looks widened. Many mediastinum can look normally widened, especially when they are taken in a supine position and patients are old, with the aorta showing tortuosity. But in this case, this was really sinister. If you see the lateral view, you can see the ribbon sign. You can see the double lumen aorta. The contrast has got differing density in the two lumens. So there is a massive aortic dissection, which is involving almost the whole aorta. So all these can manifest with findings in chest radiograph. Just now I was telling you about aortic unfolding, which can occur normally sometimes in a chest radiograph. I mean, slightly older person, you can see the aorta, but it is coming back to normal. You will just pass it as an aortic unfolding. But look at the left one, it looks a little abnormal. You see, there is some irregularity on the right border also, and some irregularity on the left border. It is not as sharp as you find here, even though this almost looks, rather this is even smaller than this. But this looks a bit abnormal. And it turned out to be a very huge mass lesion. So this much big mass lesion can sometimes hide behind the mediastinal. You see that? You take a PA view, it is just showing some irregularity on both sides. See the previous picture. See, it's widened. This widening, it doesn't look as innocuous as this widening. So this was normally this is not the way the esophageal malignancy manifests. They present with early dysphagia, and they usually are concentrically narrowing lesions. But in this case, if you look carefully, actually, even a Rayleigh tube was passed without any difficulty. You cannot identify from the screen probably, because an nasogastric tube has been passed for this patient. And only by prompting, only by further questioning, patient was complaining of a little bit of dysphagia. That is because this was primarily a huge exophytic mass involving the esophageal wall. It can only be rare things like ileoma or sarcoma or something. In other words, I kept these examples to tell you that you should have a concept about the mediastinal widening, and if anything looks abnormal, you should not have an hesitation for asking more investigations. And do you think this is normal chest X-ray? Yes, it looks normal. There are quite a lot of normal chest X-rays, but patient is definitely having some disease, especially allergic diseases, etc., which cause some diffuse lung parenchymal disease, which the shadowing is so ill-defined or so subtle that is not manifesting in a chest radiograph. But when you do a CT scan, you can actually see very soft, small nodules distributed throughout both lungs on either side, sparing the subpleural region. It's not going up to the subpleural region. So it's not a subpleural fibrosis. This is the classical picture of a subacute hypersensitivity pneumonia in an allergic patient. And he is also giving history of keeping budgies. You call it Budge-Reiger's disease, or sometimes in a general term as a bird fancier's disease, etc. So there are a group of diseases like this, not only this one is one example only, which are called interstitial lung diseases, where a chest X-ray may not be very helpful. It will only look like a dirty chest X-ray, which we used to call as a reticulonodular shadowing. That is just lines and dots, etc. But now, with the advent of CT scanning, especially with a very specific modality called high resolution CT, we do differentiate between different lung diseases. I hope in this one you identified the finding. Now, not this in just X-ray properly, but you identified probably in this one. See, you can see very small, discrete shadows distributed throughout both lungs. In a good quality chest radiograph, you should be able to see that, and definitely a CT will show it much better. And this is what is called a miliary tuberculosis. You also identify a small pleural effusion on the right side, which is not visible in chest radiograph. You know why that pleural effusion? I'm not seeing that pleural effusion here. It requires at least 200 cc of fluid, or sometimes even up to 500 cc, to manifest itself in a chest radiograph, because the costophrenic recesses are so deep. But in a CT, you need only 50 cc or even less for it to get demonstrated. So this is showing the miliary tuberculosis and the pleural effusion. And the abdomen is also showing a ascites and the presence of splenomegaly also. Normally the spleen won't come that low as liver. It's almost equal. The coronal measurement of liver and spleen are almost equal. Now we are coming towards the last part of the topics. I just want to say a few things about chest X-rays in lung cancer. That is because it's very important. There is no point in diagnosing lung cancer in huge masses like this. Anybody will say. By the time you diagnose this as a possible lung cancer in a chest X-ray and investigate it, it will be already too late. At least the patient would have had adrenal metastasis by then. And sometimes the patient might even present with the symptoms like ataxia, due to cerebellar metastasis or brain parenchymal metastasis. Instead, you should look for small shadowing. This is also quite big. Anybody knows this is lung cancer. You are not doing a great service by doing a CT scan for this patient. And this is again a mass lung cancer. This is something strange here. You can see that the mass is on either side of a linear structure. This is called an azygos lobe, actually. This is an azygos fissure. Actually, the lung cancer has engulfed an azygos fissure, crossing that fissure. Azygos fissure is a two layers of pleura, visceral and parietal pleura, through which the azygos vein goes. So that's an incidental finding. You identify the azygos vein in a azygos fissure in a chest radiograph as a comma-shaped structure. But again, another case. These are all advanced. See, you can see that the left hilum is bigger than the right. But see how big is the mass. These are all very advanced cases with a massive mediastinal invasion. But why I'm keeping all these pictures is this is again advanced. Not to show you advanced cases, but to tell you that you should start looking at it when it is very small. See, this was 2 years earlier. Now this nodule is identifiable. You should pick it up even smaller. See, this may not be able to identify it in, this is the same case. May not be able to identify, it's another case. It's an 8 millimeter nodule at lung base. This may not be visible in chest X-ray, but if it is visible, it is for you to suggest to CT and look for its volume. Because if you wait for this one lesion to become as big as this, to be shown in a chest radiograph, by the time its volume would be doubled or more than doubled. If it is a 4 centimeter lesion, if it increases to 5 centimeter, technically it is only a 25% increase in diameter. But if you consider the volume of the lesion, it will be doubled by that time. So we look, nowadays we actually don't measure these nodules in chest radiographs. If you suspect a nodule disease, or incidentally if you find chest nodules in a CT, you keep it for a follow-up CT as per specific guidelines which has been established by British Society of Thoracic Imaging. And now we actually look at the volume measurement rather than a single one direction diameter measurement. And because you depend upon an important feature called the doubling time. If the lesion is not doubled within a year, you can probably safely say it is a benign lesion. The mean doubling time can be as little as 166 days for squamous cell carcinoma. I mean, even less. Actually, average is 166. In squamous, it can be even 4 months, you see, 115 days. And maybe 7 months for source of adenocarcinoma. But even less for other things like large cell carcinoma and small carcinoma. So we look at volume doubling time in CT. But to enable you to do that, you should look for chest radiographic shadows which are visible. For example, this shadow, this is quite big and already a quite big important mass in CT scan. See, this is a PET CT image which shows us as a metabolically active lesion. So this is a cancer. But you should not ignore this shadow. This is quite visible. So always look for opacities, even if they are very small. See, look at this. Do you find any abnormality here? If you look carefully, which quadrant you will suspect a tumor? There is a lesion here. Superior right or superior left or inferior left or inferior right. Here there is something, but that is probably a masking by some soft tissue shadows. But here this is a very localized irregularity of the diaphragmatic dome. Just that much unsharpness is enough. See that? See, this is the lesion. So you should pick up abnormalities in chest X-rays when it is as subtle as this. Then you go to CT and you demonstrate that. It's another one again, very bad chest X-ray, someone with a chronic obstructive pulmonary disease. So there are a lot of chest shadowing. But in which quadrant you will suspect or place a suspicious lesion in this case? Again, right superior or right inferior, or left superior or left inferior. You feel like suspecting something here, here, and everywhere, isn't it? No, this is abnormal. This should not have been there. You see why there is such a prominence. See, it's already a lung cancer. So look for even very small shadowing. Look at another one. You find anything? You find only a vague opacity here. So you can see that overlying the third or fourth posterior rib. And in November, within 1 month itself, it has become bigger, you see. And so it's quite rapidly growing. And especially if you find such opacities in asymptomatic people. Okay, if you are suspecting a pneumonia and consolidation, you can wait for 6 weeks and take a repeat X-ray and wait for its resolution, etc. But if you find such shadows in a totally asymptomatic beings, the patient should definitely go for a CT. See, this was that case. It is already a cavitating neoplasm. And I said I'm coming towards the end, but this is just to show you what I was talking about, the interstitial shadowing in reticulonodular pattern. You see lines and nodules and everything. Looks like a dirty chest X-ray. And we do, this is what is called a high resolution CT. You pick up subtle subpleural manifestations. And we name the disease like a usual interstitial pneumonia, idiopathic pulmonary fibrosis, etc. What is important is lung cancers can get masked in these people. For example, because this chest X-ray is very bad, there was no way that particular shadow could have been seen here. There is something here. There is something here and everywhere, so you may not suspect. But you can see this is a little bit abnormal. It should not have been, left alone. Actually, it was given a chance. Someone wanted to look at it after 3 months, but after 3 months, it has become a quite big mass. So the lung cancers can occur in diseased lung as well as in normal lung. Diseased lung means lungs with some other diseases like interstitial lung diseases also. So chest X-ray sometimes gives you a shock. That is because the experience is generally, as we say, is a worst teacher. It gives the test first before presenting the lesson. So all of us make mistakes. So we should try to reduce the mistakes by looking at the radiographs carefully. Now, I just wanted to show you 2 more examples because these are coming up as important things. You might appreciate that these 2 abnormal prominence of the breast shadows on both sides are due to, what is that? Breast implants. Otherwise, you don't get this much density. But what is happening on right side? Not very clear in this radiograph, but I have zoomed it for you. You see that the duodenal air is being displaced. I have still made it, so there is some structure here. And this patient has a problem. The patient has got a fullness of abdomen and obstructive symptoms. The patient recently has had an insertion of gastric balloon as part of anti-obesity measures. And that gastric balloon is actually occluding the pylorus. So that is why the patient was in. This is a CT examination. So you look for here. So all sorts of abnormal foreign bodies you have to look for. You should know, other than the various lines and tubes which can be there in patient's chest radiograph, you should be thorough with the various foreign bodies appearance also. I particularly kept this picture only because recently in India, in our state, there had been a confusion about a foreign body, whether we actually missed a foreign body or something like that. I found at that time that many people actually were not aware that you can actually differentiate a button cell and a coin. See, this is a magnification. You can actually see the button cell has got a rim, it's got a halo outside, whereas the coin will not have that. Coin will be just circular. If you take a lateral view, this will have a step-like deformity. So it is possible to differentiate a button cell from a coin. And a coin is usually an opposite, just passes through the GIT and it should be out within 1 or 2 days. But this can, if the button cell gets stuck in esophagus, it can actually erode tissues. It can cause erosion. It can even erode into the trachea, and it even happens sometimes things like a tracheoesophageal fistula. So the follow-up of the lesion, follow-up of the foreign body is important if it is a button cell rather than a foreign body. So I'm coming back to my first point, which is that a chest radiography is a very cost-effective investigation. Normally, these are the 2 terminologies which the health economists use. See, cost-benefit is when you construct a dam, you consider the cost as well as the benefit in monetary terms. Cost of the dam or road and the benefit because of the dam or road. But in health, usually more common is using the cost-effective, and the second part is considered as an effect, and it is measured not in monetary terms. That way, I will say, in spite of all these newer investigations, modalities, and gadgets, the chest radiograph, which is 125 years old as of now, is a very, very, very cost-effective investigation. The last 4 slides I'm just running through because this is COVID season. We have been good in dealing with the chest radiographs and CTs of COVID patients also. What happens is we are looking for bilateral, peripheral, predominantly mid and lower zone airspace opacifications. These are different patients. These different patients is in a very advanced stage. See, the corresponding CT shows that the patient has got bilateral ground glass effects. So a lot of alveoli shows airspace opacification. It's a single case starting from 3-5. You can see this patient, the prognosis, the progress. Finally, there is almost no black lung. So it is completely opacified. Another case. So there had been specific guidelines for radiologists all over the world how to look at and how to report to COVID pneumonia and how to classify them. Classical COVID, COVID-like, and classical non-COVID, etc. So these are all same cases, the chest radiograph at an initial stage and a later stage. You can see that the chest rates are increasing. I just added this. Somebody else will be probably talking to you on COVID. But I just added this to tell you that in certain parts, especially when patients, a large number of patients were coming up together, chest X-ray and even CT in China, they were even using CT as a screening tool, which is probably too much as CT. You can't do CT for every patient, and if you do that also, it will require a complete deep cleaning of the machine, and your throughput through the machine will be less. But chest X-ray is okay with all proper precautions. If you do a chest radiograph, and you will find the findings, and you can further confirm by RT-PCR testing. So the British Society of Thoracic Imaging actually came up with codes. Actually, we have specific code, CVCX0, CVCX1, like that. There is for chest, normal, classic, indeterminate, and non-COVID, etc. So I just added these 4 slides. That's all. Thank you for a patient listening. I was just trying to give you an overall view of chest X-ray as it is, especially in its 125th year. Thank you.
Thank you, sir. The class was really informative. We have a few doubts from the audience. Shall I read them out, sir? Am I audible?
Yes.
Okay. One is, how can we make out whether an X-ray is anteroposterior or posterior view?
Oh, I think you missed that. I can go back. I have clearly described those things.
Okay.
In anteroposterior, did I not tell you that? Anteroposterior X-ray, the heart will look bigger because it is not taken at a distance, and because the patient is lying supine and the heart is anterior, and the documenting device is posterior. So there will be an apparent cardiomegaly, and the clavicles will not be slanting as you see it in the PA. It will be almost up and above. Plus, more of scapula will be shown in the chest radiograph. Altogether, it will show less of lungs compared to the posterior view, in which case you hold like this, as you saw the Marilyn Monroe's X-ray, you hold like this, and the scapula will be raised out of the fields. And because you are standing like this and the X-ray is shot from behind, the heart is closer to the documenting device, so less chance for heart size. So actually, you don't say cardiomegaly in an AP view. You just ignore heart size. You refuse to comment on heart in an AP view unless it is so massively enlarged also. So that is why you prefer posterior view, in which case the heart should be 1/2 of the intrathoracic diameter. So if the CTR ratio is more than that, the heart is enlarged.
Okay, sir.
Okay.
Okay. I would like to use this opportunity to thank Dr. P. Ramachandran, sir, for all the time and effort you've put into the session. I'd also like to apologize for the technical delays that were caused in the beginning. Thank you, sir. You told us about how important it is for us to know even about the subtle changes in a chest radiograph in a very simple way, and you also concluded in how we can relate it to the present COVID pandemic situation. So I hope that everybody who listened to this class enjoyed it and above also benefited from this. Again, I thank you, sir, and I shall be concluding the session. Thank you.
Thank you. Thank you.